I was speaking with my guest off camera a little bit just now about how women often want the outside to match how they feel in the inside. And this is often a topic that we see come up, especially around midlife, especially when we're getting ready to transition through menopause. Oftentimes, it's this combination of we don't entirely feel like ourselves anymore. And then we're looking in the mirror and we're seeing things that it just doesn't add up. It just doesn't match. And so the discussion we're going to have today is how can we optimize not just how we look on the outside, because we want to look good as we age, but also how can we be vibrant, healthy, and young on the inside. Today I have with me Dr. Flora Waples, and she is the founder and medical director of RESTOR Medical Spa, which is one of the fastest growing multi-location medical aesthetic companies in the United States that's dedicated solely to making aging optional for women, which I love. And I hope there'll be a location in Albuquerque one day. Uh,
Stunning.
it's coming. Dr. Flora Waples is a board certified physician. She received double majors in chemistry and biochemistry from the University of Chicago in 2000. She graduated from Cornell Medical School in New York in 2000. And then she completed her residency in emergency medicine and trauma care at the University of Chicago. And this is a training program that has consistently ranked among the top 3 in the nation. Dr. Waples has always had the dream of growing RESTOR into a complete wellness and aesthetics practice that can help her patients feel as good as they look and look as good as they feel. In 2021, Dr. Waples had the opportunity to begin a fellowship in hormone replacement therapy and longevity medicine, which she completed in 2022. Dr. Waples, welcome to the show.
I'm so glad to be here.
Well, it's really interesting. I've interviewed a lot of doctors over the course of the 5 years that the podcast has been up. And a theme that I see a lot is, and it's maybe you can, add some perspective here, but a lot of doctors will be in emergency practice and then move over to regenerative medicine. And I find that so interesting. Like how does that transition occur? What sparks that transition, do you think?
That is a great question. It's actually a great question because you're right. Like ER docs, the joke I always tell is I tell people, I'm like, ER docs, we are the cockroaches of the medical world. We can survive anywhere. Like there could be a nuclear war and we'll still be running around doing stuff. I think there's two reasons, or at least there's 2 reasons that applied for me. The first reason is that, ER docs, we exist on the very front lines of what I would say is our standard medical system. And because of that, we see the failures of our standard medical system every day in a way that maybe some specialties don't. So for example, when I was in the emergency room, I would see people with diabetes every day. I saw probably tens of thousands of people with diabetic complications, tens of thousands of people with heart attacks, tens of thousands of people with strokes. And I didn't cure a single one of them. Not a single one, right? What I did is maybe I adjusted their blood sugar, I changed their blood pressure medications, I did the best I could to sort of, help them a little bit with the acute crisis they were having. And then I discharged them right back out onto the street and I've accomplished nothing, right? Because the standard medical system, what I would say, what I would say is traditional medicine, is a disease-based practice, right? You don't intervene until disease is present. And the doctor's job is to treat disease. But aging is not considered a disease in traditional medicine. It's considered to be this natural process, and fair, it happens to everybody, but we don't treat aging. We wait until the diseases of aging occur. And then we treat those diseases, but we don't treat the underlying cause. And so the patients don't get better. When I transitioned to RESTOR, my practice now, one of the things that we do is we use the GLP-1 medications for weight management. And my patients love it because they look great in bikinis and they're happy. But what I love about it, I cure diabetes in this practice now. Because if we can get the weight loss to happen early, then the patient never develops diabetes in the first place. Or if they're on the borderline, they're starting to develop diabetes, we can reverse it. I couldn't do that in our traditional system. I can't. You're not allowed to treat until someone has the disease already. And so I think the ER docs, we see that. And so we transition. I think the other thing is ER docs were problem solvers. we're in there like MacGyver with duct tape and a hammer, and we're just going to try and fix whatever we can, however we can. We have very little respect for rules. We just want to get to a result. And I think those two things lend themselves to this branch of medicine.
Mhm. I love that perspective. I could see how that would happen because you are seeing people in this critical state. You've got to stabilize. You've just got to, I don't want to use the word kind of band-aid solution, but just find
Oh,
a
no.
solution to
Band-Aid. It
really,
is
yeah.
absolutely a Band-Aid problem. That is the whole problem in our medical system.
Now you made this transition. Let's talk a little bit about that because I have some notes here. You founded Restore in 2011 with your sister Dominique. And this I found so interesting. She was a former assistant district attorney. And I'm thinking, okay, there's a story here. We have an attorney and an ER doc, and they
Yeah.
start a aesthetic practice. How did this come about? Why aesthetics?
Yeah, well, my sister and I were very close in age. We're about 18 months apart. And we started our first business together when we were 19. She was 20 and I was 18. We started our first business together. And we always knew that we wanted to do something together. And when we got into our early 30s, it's like, well, attorney and a physician, like what can we do together? Like what branch of medicine can we do together? And then one day I went and I got Botox for the first time, and the wrinkles magically vanish, right? And I go home and I'm talking to Dominique. I'm like, I could do this. This is not a hard procedure. I could totally do this procedure. She's like, okay, med spa it is. And so she was when we opened our first location, she was about 8 months pregnant with her first kid. We had these pictures of her like on a ladder, with her tummy, of course, out to here, like carrying boxes up a ladder, like on her tummy like that. It was not well thought out to start a business at that time. But basically, I do all the medicine. Right. And she does all the business side, and she's the CEO. I'm the medical director, and it works so well, because I can just be free to think about nothing but the medicine, and I've got somebody that I can I absolutely trust, who can just manage all the other stuff that I'm not good at, and it's a great partnership. So yeah, it's what can a doctor or a lawyer do together? Well, hey, aesthetics.
A lot. And I'm sure it was a struggle in the beginning, like so many entrepreneur ventures are. I mean, having my own business and my husband has his own business. I've been on the ground up from both. I've seen what it takes. And I don't think people realize behind the scenes how the mindset part of it and how many times you just want to, I don't know, give up at some point and go, am I doing the right thing here?
Yeah, 100%. I remember, because when we started off, it was just Dominique and I, and then we had an esthetician. She was working the front desk, and I was in the back. And I remember, yeah, of course, we're early to mid 30s, and so we're having a kid every year. One of us is having like a yearly child. This went on for 4 years. And I remember sitting at the front desk, and I remember, we didn't know anything about marketing. We didn't know anything. We had no systems. We had nothing, And I was good at what I did. I'm a good doctor, but if you don't have marketing and sales and all those pieces in place, if no one knows about you, it doesn't matter, right? And I remember sitting at the front desk, and we had this beautiful desk with these big picture windows in this kind of walking mall area. And I remember watching people just walk by and just wanting to cry. I just wanting to cry because no one was coming in the door. And I wanted to like go out on the sidewalk and like shake people and be like, we're really good. Like, come in here. And it was really hard. It was very, very hard. But yeah, we had this plaque that we had on the wall, and it said, the two most overrated things in the world are natural childbirth and owning your own business. We just had that, and yeah, those first few years are hard. They're very hard. But you learn, you learn about your ability to persevere, and you learn about how to do what's necessary to get your business off the ground. I don't know if it gets easier necessarily. The challenges change. It's like raising a kid. Like you figure out one stage, and then they become teenagers, and you're like, oh crap, and then you figure out that stage, and that's a new stage. Um, but it's been really great, and I've learned so much, and been able to touch a lot of people, and that's really.
Yeah, you have to come back to your why. I think it's so important because you get these unexpected things like 2020. If you were a brick and a brick and mortar business, I know I was training people in person, and I had to completely pivot to a different model, which I already wanted to do, and that just kind of pushed me into doing it quicker. But I know, like the where I've gone to have my treatments, they had to ride that out. That was really difficult for them. It was months of being closed. And then you get things like marketing changes. That's what I've really noticed with AI. It's just wow, like over the last year,
Yeah.
completely changed how we have to do things, how we have to market and run a business. Now, shifting just a little bit, you talked about the injectables. What type of services do you offer at your medical facility?
Yeah, well, we do everything. So when I'm talking to my patients, I always tell people, the aging process has four pieces. There's four pieces. We think of it as one thing, like I'm getting old, right? But really, there's four things that are happening. So the first piece of the aging process is our skin breaks down, right? Our skin is a barrier between us and our environment. And because of that, it absorbs a huge amount of abuse, especially I mean, living in high altitude deserts, like that's a tough
Yeah.
position for skin. If you think about it, we're aquatic animals and we're living in a high altitude desert and our skin's like, 2 millimeters thick. Like that's a tough position. So our skin starts to break down and that results in, sort of lines, wrinkles, increased pigment and stuff. You regenerate skin with lasers. I think about like lasers and microneedlings, like taking our skin to the gym. You regenerate the skin with those. So we have a whole line of those. The second piece of the aging process is the muscular aging piece. So our muscles are making expressions hundreds of times a day for 20, 30, 40 years, pulling at the skin every time they do. And the skin's an elastic thing. When you pull it, eventually it loses its ability to snap back. And then we get those etched lines in our upper face. So since those are caused by muscle, we fix those with muscle relaxers. So that's all of our toxins. So Botox, Dysport, Daxi, like all of those. So we do those. And then the third piece of the aging process is that structural piece, right? So when we're young, we have all this wonderful structural tissue. It's like this Nike swoosh, and it sits on our cheekbone here, and it basically holds everything up and back, right? And then as we get a little bit older, that structural tissue starts to break down because Mother Nature sucks. And so as it's breaking down, what happens is we slump, right? We get hollow, fold, fold, which are universal signs of aging. They happen to all of us. So since that's a structural problem, you solve that with structure. You rebuild the structure with either fillers or biofillers, whatever your tool is, and you rebuild those structures. You lift everything up and back. So we do all of those. And then the fourth piece of the aging process, and really the one that drives everything else, is internal aging, right? Because all the stuff we're seeing on our faces are the result of processes that are happening inside our bodies. And so for that, the anti-aging medicine, hormone therapy for me, I don't think of it as hormone replacement therapy. I think of it as hormone optimization therapy. Like the idea is how can we get your body to function optimally? Because if we think about let's take collagen, for example, all of the lines and wrinkles in our face are at least partially caused by the fact that we don't make collagen as well when we get a little bit older. Well, why not? Because estrogen and testosterone are responsible for helping our bodies build collagen. That's why, our muscles aren't as strong, our tendons are as strong, our skin, all the parts of our body that rely on collagen for elasticity and strength start to break down as we get a little bit older because we lose those hormones. So when you replace those things, now your face, your skin, your muscles, your joints, everything can respond the way it did. So the goal is, you treat the skin aging by taking your skin to the gym with lasers. Muscle aging, you use some injectables in the upper face, you smooth those lines away. Structural aging, you rebuild any sort of lost structures. And inside the body, you optimize the body metabolically and nutritionally so that it can respond as well as possible. And that's that's the package. That's what we do.
You explained that really well because you hit on every single pillar there. Because I think sometimes maybe women or men too, they're getting the Botox or the fillers or whatever it may be, but then they're not addressing internally what's going on or the loss of hormones or their nutrition. And it really is the whole package. Now I'm in my 60s, super frustrating. This just started happening like in the last year. And I remember it happening to my mom where she would just bump herself and there would be just this looks like a, big blood bruise and that kind of thinning skin and it's like I'll wear a bracelet, I'll wear it too tight, take it off the wrong way, and there's a mark. And I'm like, what in the? And I'm doing all of the things. So I am looking at nutrition. I am using bioidentical hormones. I am doing these things, but still fighting this uphill battle.
It is an uphill battle. And it is, I think that there are two philosophies when it comes to hormones. And I think that different people follow different philosophies. I think it is every patient's choice. And I think, you know, there are people whose goal is to stop symptoms, and there's people whose goal is to optimize. And those can yield really different results. And so when you talk about skin thinning, what we're talking about there is loss of collagen. That's what we're talking about. The collagen's job is to sort of be like the springs in a mattress. It supports all of your capillaries, it supports your skin. And testosterone is really the most important one for that. That's why men don't bruise as easily as women. They have thicker skin. So what I have found with my patients when I'm dealing with thin skin is if you go up on testosterone, a lot of times, now it takes some time. It takes about 6 months to rebuild anything because hormones are very slow acting, and that's okay. They should. That's something that I have found the most useful for preventing thinning of the skin. But again, not everybody necessarily wants to be on doses of those hormones that will recreate the body they had in their 30s, because that's a very different environment for your body than the body we have in our 50s and 60s. I'm almost 50, so I'm right there with you. Like for me personally, my patients choose. For me personally, like I want to have the hormone balance I had when I was 30. That's what I want, because that's when I felt the best. And so my goal is not to create normal hormones for a 50-year-old. Pardon my language, but I don't want to be a normal 50-year-old. Screw that. That's
Right,
terrible.
right.
I want to feel like I did when I was 30. And so by recreating those levels, I can combat some of those things. But again, everyone kind of decides where they fall, where they want their levels to be and what they want their body to be like. But that's something that I have found for thin skin. I found that helps a lot.
That's interesting. That's the first time I've heard that about the testosterone. I've heard about all the other benefits, for brain, motivation, muscle, libido, all of those things. And it's important for women, like it is for me. I've used just bioidentical testosterone since I was, I think, like 51. So
Good.
it's been a while. It helped me tremendously. But let's talk a little bit more about why testosterone, why it is important for women.
Absolutely. I mean, so this is something, this makes me a little crazy. This is one of my pet peeves. So buckle up. There's this idea out there that testosterone is for men and estrogen is for women. That's this idea that's kind of percolated throughout the community. And it couldn't be farther from the truth. Women make testosterone in our bodies normally. We actually make more testosterone just gram for gram in our bodies than we make of estrogen. Right? Testosterone is a vital hormone for women. It's also true that estrogen is a vital hormone for men. One of the reasons when sort of in the sort of Arnold Schwarzenegger bodybuilding years, when people were using a lot of anabolic steroids and blocking their estrogen, about a third of men, they should have about a third as much estrogen in their body as they have testosterone, or there's a ratio of about 3:1. And if you block their estrogen, they start developing crushing heart disease, because estrogen does the same job in a man's body with protecting their cardiovascular system as it does in a woman's body. So both sexes need both. We need them in very different ratios. We need them in different amounts, but we both need both. In women, testosterone does the same things it does in men, right? It increases our muscle ability, specifically our endurance. It's really a cardiovascular endurance. It's not so much of a explosive power type hormone, but it is a hormone that supports our endurance capacity, supports our brain, supports our sleep, and does support collagen formation, not just in skin, but in hair and in joints. Because if you think about our hair and especially the tendons and the ligaments in our joints. So when I first started testosterone, I think I was 43 or 44, something like that. And I was 30 pounds overweight. I was pre-diabetic. I could not run a mile. My knees hurt all the time. I'd never really been a runner before because my knees just hurt all the time because I have very hypermobile joints. I was in low-grade chronic pain all the time. About a year after I started it, I could feel like the ligaments in my knee, like the patellar tendon in my knee, I could feel it was getting thicker. I could feel it was getting harder. And my knees stopped hurting. And that was from collagen deposition into those tendons get thicker and stronger, right? So the same way that testosterone, like men have fewer ACL injuries when they're soccer players because their ligaments and tendons are thicker. That's a testosterone effect. When females have the appropriate amount of testosterone, their tendons and ligaments are thicker. Their hair is thicker. Their bones are heavier and their skin is stronger. It has all of those effects. It's a vital hormone. And what bugs me, I'll tell you, this is the thing that bothers me the most. When we get labs on our patients, the labs are age gated. And what that means is it is considered normal. It is in the normal range for a woman who's postmenopausal to have a testosterone level of 0. That's considered a normal lab. And that makes me insane because, yes, do our ovaries fail? They do. But we need to treat that as what it is. That is organ failure. That is a major organ of our endocrine system that fails. And to say, okay, well, you're an organ failure now and you feel terrible and all these things are falling apart and you're breaking your hips, but it's normal. It is It happens to everybody, but it is not optimal. So that makes me crazy. So yes, testosterone matters. It is vastly underprescribed. It is vastly underutilized, and it changes people's lives. I'm training for an ultramarathon now. I'm almost 50. I could not have envisioned that. I could not, it would not have been possible. My body would have broken down. My knees would not have been able to do it. And it's that kind of transformational change happens, but it doesn't happen enough. And that makes me crazy.
I agree with you. I agree with you. I know when I first started hormone replacement therapy, I was so afraid
Yeah.
to do, well, hormones in general, because I was going through midlife at a time where the rhetoric was this is dangerous, it could cause breast cancer, cardiovascular disease, on and on and on. So I was very afraid. Glad I got past that, but I was in particularly nervous about the testosterone. Now, how do we know? Because this has happened to me. It's really hard to get the levels right, and I've done different things. So I started out with the cream, the testosterone cream, and then it reached a point it really wasn't absorbing very well. So I moved to the injections, which is what I do now, which is working pretty well for me, and I can easily adjust it up or down. It's funny, I started twice a week. I forget the exact dose. Then it was once a week. And now I've cut that down to because my levels went up really, really high. How can we manage this? What is the optimum levels?
That is a great question. That is a great question to which there is no answer. And that's what makes it tough. So there are two ways to treat patients. And again, there's no right or wrong, but there's different ways to do this. So one way is to treat the blood level, right? You draw the blood, you look at what the level is in the blood, you dose based on that. The other way is to treat the patient's symptoms. And you ask the patient, hey, how do you feel? Are you having side effects? And you treat based on that. I treat based on the patient. And I'll tell you why. Blood levels have some inherent limitations. Not that they're wrong. They can be very, very useful tools, but they have some limitations. And the analogy I use is this. Measuring something in the blood does not tell you whether or not that thing is getting into the cell and whether or not it's actually acting in the body. So measuring a level in the blood is like looking at, like, is kind of near our location here. And I can look at I-70 and I could count the number of trucks going by that say King Supers. I could do that, right? And that would give me an idea about how much produce is being shipped into Denver. It would not tell me if when I go to my King Supers by my house this afternoon, if there's produce on the shelves, right? That's the analogy I use for blood levels versus tissue levels. We can't measure tissue levels, right? Unless you do, I guess, a biopsy, which would not be very,
No.
you can't do a lot of those. We measure blood because it's easy, right? It's very easy to get a blood sample. But whether or not the blood levels and the tissue levels correlate can be a real problem, especially for thyroid. This is a very known problem. The reason why they don't always correlate is this. In order for a hormone to act, it has to get inside the cell and act on the DNA. That's how hormones act. Well, how's the hormone get inside the cell? Well, we have these receptors, and I think of them like little baseball mitts, or little like butterfly nets that stick on the outside of the cell. And as the hormone is going by in the blood, it catches it and pulls it inside the cell, and then it acts. Well, some people, they got a catcher. They've got a starting catcher for the New York Yankees. Every single time a testosterone molecule goes by, man, they got it and they're pulling it inside. And their blood levels and their tissue levels are going to correlate really tight. So that's a patient when their blood level says they're in the right range, they're going to feel like they're in the right range. Awesome. That's wonderful. That's a wonderful thing. Some people have got Bobby from Little League, and he's, doing this, and the testosterone's going by, and he's not catching it. And those are people where their blood levels and their tissue levels are not going to correlate. So those are patients where when you look at the labs, you go, well, the labs say you got enough. The patient's like, yeah, but I feel awful. Like my libido is not there. My endurance is not there. I don't feel good. And in that situation, you can do one of two things. You can either say, well, I'm going to treat the lab as a source of truth because it's a number and it's on paper and I can look at it. Doctors love that. We love having concrete things that we can do. Or you can say, well, you know what? I'm going to treat this patient's body as a source of truth and I'm going to treat the symptoms. And so there's pluses and minuses to both approaches, but I treat my patients as a source of truth because we have data, like especially on thyroid. We have data that says that there's a significant portion, and women more than men, no one knows why, but there's a significant portion of people who, even though their TSH is in normal range, they are clinically hypothyroid. Their body is not getting enough. It is not getting into the tissue correctly. And in those people, you need to raise their TSH levels above the normal range in order for their body to have the correct response. And that scares a lot of people, and I understand that. When I'm treating patients, I look at levels, but then I turn to the patient. I say, how do you feel? How do you feel? We talk about if they have too much in their system, they'll have side effects. We can talk about those things. The patient can know those things. If they're not feeling good, I want to hear about those things. And if the patient's symptoms and the blood levels don't correlate, the patient is a source of truth. I believe that's important. I think that it is too easy to just look at the blood levels and go, your labs are normal. That happens all the time, right? I'm sure I've heard that from
Yes.
your own physicians. We all hear that, right? Your labs are normal, but I feel terrible. Well, your labs are normal, right? And that's the end of the conversation. So to answer your question, when I treat testosterone, I prefer injectable. I think injectable tends to work better. The creams are nice because you don't have to inject, but there's a lot of variability in terms of how hard you rub it in, over how large of an area, how thick the skin is. There's a lot of sort of squishiness there that can get people into trouble. I don't love pellets. I think a lot of people do. There's nothing wrong with pellets, but you get these big swings. You
You
get
do.
high and then you're low. You're high and then you're low. And they're hard to adjust. So I do prefer injectable. I think for the exact reasons you say, the dose is going in. And it's very easy to adjust. You can adjust from week to week or from month to month if you want to. It's very, very easy to adjust at any point if a patient starts having side effects. And when I am dosing, I don't really look very much at the blood levels. I ask the patient how they're feeling, and I ask the patient if they're having side effects. I dose based on that. And I find that the results that I'm able to get for people, a lot of times they'll say, wow, I've been on testosterone for years. I've never felt this good. And I'm like, well, probably you're one of those folks who has Bobby from Little League for your receptor. Your blood levels and your tissue levels aren't correlating, and we can help that. I like injectable, and I dose until the patient feels good and doesn't have side effects, and that's my source of truth.
That makes a lot of sense. And my nurse practitioner has a very similar approach because she'll say, she'll talk about the signs to look for, like perhaps maybe irritability being one if you've got too much testosterone where you're in traffic and just kind of. And it's true. I can tell with myself, that'll be a major one that I'll have where I'll just feel angsty, just not myself. It's like, okay, pull it back a little bit. Very easy to adjust. Now, looking at all of the hormone, well, not all of them, but the three major players of progesterone, estrogen, testosterone, I feel like there's this little dance to get them in balance where, okay, somebody could maybe have low testosterone, but it's high in relationship to estrogen. Same with the estrogen progesterone, where they're estrogen dominant, even if it's low because it's high in relationship. How do you go about getting that balance? Is it a similar approach of looking at how the patient feels?
Yeah, it can be tricky. It can be tricky because they all influence each other, right? And so I think about it like, those Jackson Pollock, those mobiles, like you hang over a baby's crib, and if any weight you put on any one of the little arms will change the way the whole thing sits. Yeah, estrogen and progesterone have to be in balance. You can do that. That progesterone is one where the blood levels and patient's symptoms often correlate very tightly. That's one that's a little bit easier to dose off blood levels. We know that we need to be above a certain blood level to prevent uterine cancer, to protect, against that estrogen dominance. But again, it kind of comes back to, almost always it comes back to symptoms for me. So, for example, estrogen dominance, you get the 5 Bs, right? Did you know the 5 Bs?
No, I don't think I do.
I'll share them with you. It involves cursing, which is the best mnemonics. But when somebody has excess estrogen, they're going to get breast tenderness, bloating, bleeding, blemishes, bitchiness, right? Those are
Mm.
those are the things that we experience when we're estrogen dominant. And so I ask my patients about that. And then I correlate that. I know their blood level needs to be above 60 for them to get the maximum bone protection, maximum brain protection. So if their estrogen is below 60 and they're having those symptoms, we're going to come up on progesterone and try to slowly go up on estrogen to get them to where they need to be. If they're above 60 and they're having those symptoms, maybe we can come down a little bit, and reduce it that way. So it's one, you pull either lever, but you just want to make sure that their estrogen's above 60 and that they're not having the 5 Bs. But yeah, it's balancing them can be difficult because also testosterone gets turned into estrogen. A percentage of your testosterone is going to get turned into estrogen in your body. So when you go up on testosterone, you're also going to have a little bit of that estrogenic effect, which is where some of that irritability can come from. So sometimes when you go up on testosterone, you go down on the patient's estrogen as well. So it's always, whenever I change anything, I'm always thinking about all of the hormones in the axis and how they're going to balance and how they're going to affect one another. And it can be a little tricky, but also it's so much fun because, man, when you get it right, and patients feel good and they come in, they say things like, I haven't felt this good since I was 30. This changes my life. Like, That's really fun. That's really fun. And I also find that, patients are smart. Patients, know what's going on with their bodies. Like, I can say to a patient, hey, listen, we have this half milligram increments. You're going to go up a half milligram every 3 months. Here's the side effects to watch out for. If you have these side effects, give me a call. We'll reduce it. We'll manage it. We'll tweak it. And patients, I think that patients are very, very capable of doing that. And I think sometimes in our medical system, we don't allow our patients to have. We don't listen to the wisdom that our patients can bring us. I don't need to do anything. My patient will tell me exactly what they need if I ask the right questions. And if I just ask the right questions and I listen, the patient will tell me exactly what I need to do. And then I look like a hero. And I love that. So yes, keeping them in balance is very important. It's kind of an ongoing process that you have to do every time you change your medication. But your patients, once they know what the side effects feel like, they can tell you. So that makes it a little bit easier.
Now, do you find it more difficult when a woman's in perimenopause? Because I have a lot of clients who are in the perimenopausal window, and it was almost easier for me because by the time I sought treatment and help, everything was flatlined. Like
Mhm.
everything was gone. So it made it a little easier to treat in a sense, to get to a balance because one wasn't going up and then going down. And when you have those late perimenopausal years, where perhaps they're still cycling or they're missing a cycle, boy, what a roller coaster ride. How do you help them through that transition?
Yeah, that is tough. Perimenopause, one of my mentors refers to it as no man's land, because it's very difficult to treat because of exactly what you said. When we start hitting, and perimenopause is much longer, I think, than most people think. Perimenopause lasts on average about 15 years. We start having symptoms usually late 30s, early 40s, goes on through our 40s to our mid 50s. It's a significant piece of a woman's life. And I feel like there's a real gap. We think about premenopause, we think about postmenopause, but women have 15 years of perimenopause, and we need to think about that too, because it's a highly variable state. So when you're in perimenopause, early perimenopause is relatively easy to treat because the first things you lose is testosterone and progesterone. Those are the first things you lose. So you replace those, women do pretty darn well. When you start getting into the later perimenopause period, what happens is your estrogen starts having these wild swings, right? And that's what's the hot flashes and a lot of the symptoms that people experience. You have these huge swings. And so there's times when they're too low in estrogen, there's times when they're too high in estrogen. And those things can be a couple of days apart. Those can be hours apart. It's incredibly fast fluctuations and it makes people feel absolutely horrible. And the difficulty is, well, if the estrogen's doing this and your medicine is doing this,
Right.
how do you balance those things?
Right.
So there's a couple of tricks. People don't know this and don't utilize this enough, I think. But progesterone stops hot flashes. Not when your estrogen starts getting really, really low, but in that perimenopausal period, if you treat with progesterone, you can stop most hot flashes. You can stop a lot of those symptoms. Testosterone also is super useful in that period because since it gets turned into a little bit of estrogen, you just have this kind of little low grade constant trickle of estrogen. It blunts some of those downswings. The high swings, those you can't really do much about those, but you can make it so you never go below a certain floor. I think that one of the biggest mistakes that people make is they try to use estrogen to treat perimenopause. And that's very, very tough. Not saying it's wrong. I mean, I understand the theory behind it, but when you get those high spikes, people can get really so the 5Bs can be a real problem if you use too much estrogen in perimenopause. So my plan for my perimenopausal women, and most of my patients are actually perimenopausal. The area that I live in, most of my patients are in their 40s to 50s. And so I don't have a lot of the sort of late postmenopausal women. But the way I do it is the first thing I do is I put on progesterone and we run that for as long as we can. Progesterone and testosterone. At a certain point, usually you can do that for several years. And then at a certain point, the woman's going to start to have breakthrough hot flashes and breakthrough symptoms of postmenopause or late perimenopause. And when they start having those symptoms through maximum dosing of progesterone and testosterone, that's when I add estrogen. I add it at the lowest possible amount. I mean, estrogen is super important and you've got to have it. It's a vital hormone.
It
But
is.
during those perimenopausal years, you want to try to keep it so that they never get too high because that's so unpleasant for people. So I add it at as low a dose as I can, and then we increase very, very gradually over the years as their own estrogen production kind of starts to calm down and drop off, and then I can get their estrogen level stabilized. But yeah, perimenopause requires constant communication with your patient. They have to understand that there's going to be these fluctuations and what to do when they have these fluctuations. You have to be ready and willing to adjust medications very frequently. I think there's a lot of docs that like put a patient on a patch and they're like, "See you in a year," and perimenopause that just kind of doesn't work. And patients have to understand that they're going to fluctuate, understand that we're going to be adjusting medications frequently. And then when you get to postmenopause, yeah, it's so much easier. You kind of get your set point and then use
Right.
it. But it's a difficult time to treat. You have to be paying very close attention.
Yes, I agree. I mean, I use the patch. I used to use the cream once again, and then same thing happened. I just felt like the receptors, it just wasn't, I wasn't really getting the benefit. So switched over to the patch, but I did find that I got a few symptoms that I had not had in a very long time, like the breast tenderness,
Yeah,
and had to pull back
yeah,
and like, okay, well, it says twice a week. I think I'm just going to do once a week or take this off and take a couple of days off. And I did this on my own, just kind of paying attention to my own symptoms and sort of adjusting as I
yeah.
felt I needed. Now, with estrogen, can we get too much? Is okay, let's say there's the vaginal, and then maybe you have the patch or the cream, and then now we're seeing the estrogen creams on the face.
Hmm.
Can you get an overload there?
Yes. Yeah, absolutely. I think that with every hormone, when you get too high, you start having side effects. So if you have too much estrogen, the main sort of skin side effect you're going to see is you're going to see acne. When you
Mhm.
have too much estrogen, you're going to have acne. And if it gets, obviously when it gets much too high in the blood, you can have other effects that are much more serious than that. But, estrogen creams on the face, it's an interesting question. I understand the thought process. The thought process is estrogen will promote collagen deposition. Collagen deposition is going to help fine lines and wrinkles. It has a real effect. It's good. In my mind, I'm like, well, but I want those effects everywhere in my body. I don't just want my
Yes.
skin to look good. I want my joints to feel good. I want my bones to be strong. I want my heart to be healthy. So, for my mind, like for my patients, if they ask about estrogen creams, I'm like, let's just do some systemic estrogen. Let's get those effects everywhere. I don't see much of a point if you're deficient in estrogen to the point where you need a cream to help your skin. Then you need that everywhere. Your skin is the external thing that you see, but what's happening to your skin is happening to every system in your body. And I don't see the point in having healthy skin draped on a sick body. Like, I want it all to be healthy. So, do I understand the science behind the estrogen creams? Absolutely. Do I see much point to them? No, we should just be on estrogen itself and then fix the problem from the inside out. But to your point, if you have too much estrogen, yeah, you get a whole bunch of acne and it really won't help the situation very much.
I didn't realize the acne. I've always heard that with testosterone, but I had not heard
Of
that with
course.
estrogen.
Yeah.
So
Well,
very,
both of them.
very interesting. Now, for we lose this collagen, and a lot of us run out, like myself, and buy an expensive collagen powder. And I just often feel like it's not doing that much. What are your thoughts on supplementing with
Well,
collagen?
so this is the analogy I use in my patients is I say, imagine a factory. Okay. Now, a factory needs several things to work correctly. Let's say you've got a factory that's building cars. You've got to have aluminum coming in and steel coming into the factory. You got to have your raw materials. And then the machines inside the factory have to be functioning correctly. And if you have good raw materials and good machines functioning, you're going to get output. So, kind of taking that to collagen. In order to build collagen, you've got to have the raw materials, you've got to have the building blocks. But you also have to have the genes that tell your body to make collagen turned on. And that's the machines in the factory. If the machines in the factory are broken, if they have no power source, if they're not turned on, you can shove raw materials into that factory all day long. You're not going to get a finished car on the back end because the problem is not the raw materials. The problem is the factory itself. So, do collagen supplements help? They can help if the problem is raw materials. If you're deficient in your diet, if you're not getting
Right.
enough, and if you have the hormone support, if the genes are turned on so that when you get the raw materials, the body is capable of making collagen, yeah, they'll help. So there are situations in which they can help. For most people, especially the patients that I take care of, nutrition, there can be nutritional deficits, but getting collagen is not their problem. Raw materials are not their problem. The problem is the factory is breaking down. And so, to your point, I think that collagen powders will only help young, healthy people whose diets are not good. If your diet is good and you have good, and the machines in the factory are working, you don't need it. If your diet is good and the machines are broken, it's not going to help. You got to fix the machines first. Now, if you get on, hormone replacement therapy, you get the machines working well, and then you add some collagen powder, yeah, it can help, absolutely. But it's a limited use case. Yeah, putting raw materials into a factory that's broken doesn't help.
Yeah, it's just something I've kind of made the decision recently to just kind of pull back. It's an expense and I don't see a huge, huge difference. My diet is good. I am on hormone replacement therapy, so I'm doing what I can. Now, what about and this is collagen loss too, but I get this question all the time is the crepey skin, and it's the arms, it's the legs. It's because I feel like so many treatments are focused just on the face. But when you're aging, oh my goodness,
It's everything.
it's head to toe. Yeah, it's everything.
Totally. And also, I'm just going to say, you look absolutely fantastic. Like
Oh,
your skin
thank
looks
you.
beautiful. I mean, if I didn't know that you were in your 60s, I would not have
Thank
guessed.
you.
You're doing a lot of
Thank
things
you.
right. So we'll
Thank you.
but of course you're doing things right because you're have a good diet and you're exercising, you're doing all the things. So that's fun. So yeah, so skin, skin is an interesting organ. When I think about skin and muscle are essentially they have the same embryological origin. They're very, very similar tissues. So when I think about skin and how I'm going to address skin, it's very, very similar to the way you're going to address muscle, right? So muscles have the ability to regenerate, which is a super cool concept, right? We don't really, take that as much, appreciate that as much as we should. Like if I cut off my arm and I grew a new arm, I'd be like, oh my God, that's a miracle, right? But the fact that we can regenerate muscle, that we can go to the gym and build new muscle, we just take it for granted. But muscle can regenerate, skin can regenerate. But both of them are lazy organs. And what I mean by that is regeneration is metabolically expensive. Your body's not going to do it unless it feels like it's necessary. So, how do you tell your muscle that it's necessary for it to regenerate? You put it under stress, right? You go to the gym, small repeated stresses over time, right? You don't go to the gym for 18 hours once a month because that would be awful, right? Like you just injure yourself, you'd be crippled, maybe a terrible situation. Nothing would happen, right? Because your body doesn't respond to huge input once. It responds to repeated stresses over time. And what will happen is the first couple of times you do it, your muscle will just be like, ow, ow, I don't want to. And then if you keep putting that muscle under small repeated stress, the muscle goes, okay, clearly this is what we need to do now. Muscle starts to regenerate, muscle grows. Skin's exactly the same. Skin regenerates in response to stress the same way that muscle regenerates in response to stress. But you can't lift a weight with your skin, right? We don't, that would be a weird thing to do. So the way that we put skin under stress is we create sort of microscopic level controlled wounds, tiny, tiny microscopic wounds, small stresses over time. So if you think about it, we can create those controlled wounds in any number of ways. Lasers use heat, microneedling uses physical puncture, chemical peels use acid, right? But they're all getting at the same basic concept, which is that small repeated stresses over time will induce regeneration in skin. Coming back, our face and body, the same organ, they're absolutely the same organ. Every tool that I can use on a face, I can use on a body. And so when we have crepey skin on our arms, microneedle RF, ablative lasers, those tools will work to be applied regularly over time, but they will absolutely work. I think that it tends to be a pocketbook question. Like these
It
treatments
does.
are expensive. What is it that people see the most? They see our faces the most. And so we tend to invest the most in our faces. But can the same techniques be used everywhere on the body? Absolutely, without a doubt. And for my patients, we tend to focus on the tabletop. I'm like, you don't want floating head syndrome. You don't want a face that's 20 and a neck that's 50. Like that's not the goal.
Right.
Like you want it all to be kind of homogenous. So I tell my patients, for every 4 treatments you get on your face, you should get 1 treatment on the tabletops, and that's neck, décolleté, shoulders, hands, because our hands sometimes age us quite a bit.
Oh, yes.
And so, every 4 on the face, 1 on the tabletop, and that will kind of keep them sort of congruent, and that's the goal. But yeah, every treatment that works on a face will work anywhere on the skin. Same organs, same rules.
Do you think microneedling is the best approach? And I'll kind of back it up a little bit. So I've tried so many different things, and I did microneedling on the face. Really loved it. Loved the results I got from that. I haven't tried it in other areas of my body. I'm considering it now that you said what you did. But I tried a treatment called a thermage several years ago, and it was too painful for me.
Yeah.
They were doing it on the legs. I was getting ready. I used to do bodybuilding competitions. And when you compete and you lose all the body fat, your skin, not just on your face,
Yeah.
but your whole
Yeah.
body
It's lax.
takes a hit. Yeah, it gets yeah, very lax and can get crepey, can get loose because you lose that body fat. And so I was having a treatment done, and I couldn't handle that burning sensation of that laser. I could not deal with it.
And that's a common complaint. There's the scientific reason is this. And this is one of those like physics problems that the aesthetic field has been struggling with for 20 years. And we're getting better and better at it. But this is the basic problem. In order to get tightening of skin, you've got to get that wound, if you will, that microscopic wound, that thermal energy, you've got to get it down into the deep layers of the skin where the collagen is being generated. Now, the problem is you got skin, that's this layer down here. How do you get, if you put enough heat on the surface to get the bottom layers to get hot, you're going to burn the surface. That hurts, it's disfiguring, scarring. So the problem is, how do you get a lot of energy down here while only getting a little bit of energy up here? That's the basic physics problem. And people have come up with a variety of ways to overcome it. But the is something that pierces the skin, similar to microneedling, but that then generates heat once it's underneath the skin. So microneedle RF is microneedles basically plugged to a laser. So the needles go through the skin like this, and then only the bottom of the needle gets hot. So you get heat underneath the skin, no heat on the top. That works very well. People also will use things where they'll take a little tiny catheter and thread it underneath the skin, and then like the J plasma machine, and it got bought and rebranded. I can't remember the new name, but basically you run this little catheter under the skin, and so again you heat that lower layer without heating the top. Thermage, the problem that Thermage had, and I never purchased it because this was a known problem, is that they're putting the heat on the surface, and the patients can't tolerate the amount of heat that's
Right.
required to get real tightening. Generally speaking, people got really kind of lousy results. The science, the idea was sound. The idea of we're going to put heat here and that's going to regenerate tissue is a sound idea. But the problem is you've got to get the heat underneath the skin without damaging the surface skin. And the only way to do that is go underneath the skin. So microneedle RF works very, very well. The ones with whose names I'm blanking on, I do apologize for that. But the ones where they run a catheter in the skin work incredibly well. Incredibly well. And then of course there's always surgery, right? You take the excess skin, you cut it out, but of course that leaves scars. So my go-to for tightening on the body is microneedle RF. If you're going to use one of the catheter directed fiber optic ones, you want to make sure that you're seeing somebody who's highly skilled, hopefully a surgeon, because anytime you're going underneath tissue, it just takes a level of skill that's a little bit different. Microneedle RF is very, very user friendly from the clinician standpoint because the needles can only go so deep. If you've got a catheter, man, you can get into a
Oh,
structure
yeah.
you're not supposed to, that can cause problems. So you want somebody who's very good to do that. But they both work very, very.
And are they very expensive? Expensive procedures?
It varies, as all things. Generally speaking, microneedle RF procedures are going to cost around $1,000 ish for an area that's kind of about, sort of a foot square. So, and you're going to need a series of between 4 and 6 spaced out over a month, similar to going to the gym. You got to do these small regular stimuli over time. With the catheter procedures, I honestly, I don't know. I think they're more like 3 to 5,000, but you need to do fewer of them. But there's more discomfort and downtime during, so it's kind of there are good arguments for both. But the investment will be about the same. I think I'm not an expert in those procedures because I don't personally do them, but the financial outlay will be about the same either way you do it.
Okay, yeah. And I would think it would be a good option for somebody like me where you're thinner. And so going to a surgeon and saying, cut off the excess is maybe not the best thing,
Yeah.
especially if your skin is thin, you yourself are, you're relatively thin, relatively small person. I would think that those other procedures would be more effective.
And I will also tell you that thinner people get better results because it is easier to heat up something that doesn't have a lot of thickness. It's easier to get heat into it. And the more heat you get, the more response you get. So generally speaking, it is easier for me to treat somebody who's on the thinner side than it is to treat somebody who has a little bit more padding. So that's good news for us.
That is good news. That is good news. Now, looking at the treatments on the horizon, we know we have the fillers and the Botox, very effective. It's a non-invasive way to get those results. What is new? What is out there on the horizon for treatments right now?
Well, it is such an exciting time. It's such an exciting time, Carol. You know, the tox and filler and all those things, they help mask or they help replace things that are causing because of the underlying aging process, right? Things that are being caused by the underlying aging process. What is happening in aesthetics right now is the field of anti-aging regenerative medicine and the field of aesthetics are in the process of kind of merging. And they should, right? Because they're doing the same thing. The underlying goal is how can we keep our bodies healthy? I hate the word longevity medicine because in my mind, that's like, I want to live to be 120. It's like,
I
look,
know.
the age is not the point. Vitality is the point. Health is the point. How do we keep our bodies from breaking down over whatever lifespan we have? How do we keep our bodies from breaking down? So all of the new aesthetic treatments are treatments that are similar to the anti-aging treatments, which is the idea is, can we give the body a signal that tells it to act the way it did when it was 20? And here's why it works. Go back to that factory analogy. I love the factory analogy. Our genes make us, right? Our genes make possible everything that our body does over the course of our whole lives, right? Our DNA, our genes, the genes we have when we're born are the same genes we have when we're 30. They're the same genes we have when we're 60. They're the same genes we have when we're 90. All of the instructions are there. If we're going back to that factory analogy, all those machines, the machines don't change over the course of our lives, but our bodies change over the course of our lives, right? So the question is always why? Why do our bodies change when all the instruction manual, the instruction manual is there, the instruction manual hasn't changed? Why is our body changing? And the reason is because genes get turned on and off over the course of our lives. Environment, diet, hormones are a huge part of that. There's a lot of different pieces of that. But basically what happens is over the course of our lives, it's like someone walking into this beautiful factory and just taking the instruction manual and just ripping out pages. And now those machines can't work. The machines are still there, but they don't have the instructions. And so they just grind to a halt. And that's why our bodies break down on the inside and on the outside both. So all of the new therapies are kind of saying, how can we give our bodies back the instruction manuals, turn on those genes that have been turned off? And that's exosomes, that's PRP, that's stem cells, that's hormones. All of those things basically are trying to turn genes back on so that our bodies just act right, so that we don't need filler and we don't need tox. Our body just acts right, because it has the instructions it needs. So for example, let's talk filler. Love filler, have it in my own face, it's fantastic. But it's a synthetic analog, right? I am trying to replace collagen and fat that I've lost with a synthetic structural molecule that I'm injecting, right? Biofiller is kind of the new thing that we're using a lot of. I absolutely love it. It's only going to get better with time. What biofiller is we draw your own blood, we spin it down, we collect the PRP, get it into this albumin gel, this is all bioidentical to you, and we inject that. It gives you structure, but also the PRP that's mixed inside it causes the tissue to regenerate over time. So what you get is your own volume, your own body's native volume, and it looks better because the thing about fillers, look, I love fillers. I've been injecting them for 15 years, right? The thing about fillers is they don't always look exactly right because they are not the same as our native tissue. They can be too rigid, they can be too soft, they can be lumpy. These are things that happen to us, right? And of course that's the way it is. It's impossible to make something synthetic that exactly replicates a human tissue, right? Human tissue is too complicated. But when I can regenerate someone's tissue with a biofiller, it moves and acts as their normal tissue did. And that's super cool. It looks natural because it is natural, and that's the goal. The goal is regenerative aesthetics, not synthetic aesthetics. Regenerative aesthetics. Your body looks beautiful because you're healthy and because the machines in the factory are working like they should. So the things that are coming, more and more exosomes that are capable of turning on different functions in the skin, more and more biofillers that are capable of generating native volume. That's your own, native volume, things of that nature. That's what's coming. And it's such an exciting time. You see this because you look at Hollywood. About 10 years ago, a lot of ladies in Hollywood were starting to look a little weird.
They were.
There was
Agreed.
puffy, rigid stuff going on. People were looking a little funny. People now, all those people who were looking a little funny before are starting to look really good again. You notice that?
I have.
That's what it is. It's this regenerative revolution that's happening in aesthetics now. It is totally different from synthetic, tools, and it looks so good. It looks so good because it's their native tissue. It works beautifully. So that's what's coming.
Are you doing this now in your practice?
Absolutely.
Oh,
Absolutely.
wow.
It's
Exciting.
wonderful. It's so exciting. And it will only get better. We are just at the beginnings of this revolution where we are truly figuring out not how to give drugs to the body, not how to mechanically change the body, but how to actually harness the body's own regenerative capacity. And that's going to change everything. It's going to change aesthetics. It's going to change medicine. It's going to change our lives. It's just, I am so grateful to be alive in this period of time because it's an exciting time to be in medicine and to be alive, just generally speaking. But yeah, it's great.
It is. It really is. I love the idea of the biofillers because, yeah, fillers, I've had them too. I've had Botox. I've had all the things probably off and on over the last 10 years.
Sure.
But what I found was the fillers got a little more challenging the older I got because they can start to look a little weird. You can look more bloated or
Yeah.
puffy or inflamed
Yeah.
rather than younger. It just, yeah, and a little goes a long way. And I've had to learn that one the hard way, overfilling a couple of times. Yeah, because you look, I think it was perhaps maybe Madonna a few years back and everybody was talking about her filler and I
Yeah.
felt so bad for her. And that was, I think, the classic case of rather than looking younger, looking just kind of bloated.
Yeah. Yeah. And also that was also a classic problem of, like the aging process has four parts. If you just treat one, you're not gonna it's not gonna look natural, right? Like if you just fill instead of trying to make the skin healthier, make the skin tighter, make the skin more luminous, if you just fill, what you get is puffy moon face. And that's not a good look
Yes. Yeah,
because that's
that's
not
it.
native to your body. You need to balance treatments so that your skin and your structure and your muscle and your inside of your body are all equally healthy. They're all in the same place because that's what gives you a look that looks natural. Like I don't think that beauty is health, right? That's really what it is. When the human eye is looking for beauty, what we're looking for is vitality, health, and happiness. Those are the things that the eye interprets as beauty. And trying to replace vitality and health with volume, it just doesn't work. It just, you
Right.
get puffy moon face and you're rigid and you don't look good. It doesn't look right. So yeah, very important to treat all pieces of the aging process and very important to treat them in balance with one another. And yeah, regeneration beats synthetics every day of the week.
Agreed.
I think that 10 years from now, we'll be kissing our filler syringes goodbye. Maybe not 10, but soon. We'll be moving entirely to regeneratives because they will just be superior. That's what I think. We'll see. Well, you can call me back in 10 years. We'll find out.
Exciting. You need to open a place here in Albuquerque. Often we're the last in New Mexico to get the new treatments.
Yeah,
We're small and
yeah,
it takes a while for everything to work
yeah.
its way here.
It does.
So hopefully soon. Well, Dr. Waples, this has been so much fun. Really unpacking all of this with you. You have a lot of knowledge, and I love just your excitement about medicine and what's happening and running the ultra marathon. You've run one or you're getting ready to run one.
Again, super easy to say you're going to do it, right? But August 30th, I am going to
Oh,
attempt. Let's just say I'm going to attempt. That's as much as we can say now. I'm going to attempt one. We'll see how it goes.
I love it. Where at? Where will this be?
It's called the Grand Traverse. It's from Crested Butte, Mass.
Yeah.
So
I know
41
where that is.
miles. And the thing that's tough about it is it starts at like 8,000 feet and then goes up to 12 and then back down to 8 and up to 12. You go over some mountain passes and it's just incredibly beautiful, incredibly beautiful. But I mean, if I don't succeed this year, then I'll do it again next year. If I don't succeed next year, I'll do it again the year after. And the mountains aren't going anywhere, and I'm not going anywhere. And I will eventually get it, but it's a challenge. So we'll see.
It is. I've run many a marathon. I used to be a marathon runner, but never the ultra. But I did do a quad one year, the Mount Taylor, which is the run, bike, snowshoe, ski, cross country ski, and then reverse it on the way back
Oh,
down. So
love that. No, I
that
love
that
that.
was that was not easy.
That's
So
something.
yeah, it was something. It was a thing.
It definitely takes a complex form of stupidity to decide you're going to do something like that.
Does. And I was definitely suffering by the end. I was like, what am I doing?
Yeah, around about mile 20, you're sort of like, what?
Oh yeah,
What?
and your mind does these weird things. I remember like seeing a burger place and going, "Oh, I should just stop and go in there and eat and
Yeah, yeah.
something else."
I did a race once where there was because sometimes you get a little confused, and
Right.
I did a race once where there was a bottle of Coke that was following me for about 2 miles, and I kept being like, that bottle of Coke, it doesn't know the way. I'm just gonna get going. Looking back on it, I'm like, boy, I maybe I was a little dehydrated.
And probably yes.
Yeah.
Well, Dr. Waples, thank you so much. As we wrap up, how can listeners learn more about you, follow your work, and maybe even visit one of your clinics?
Absolutely. The best place to go to learn about what we do is our website, which is www.restormedicalspa.com. It's RESTOR, no E, because we're very hip people. But on that website, you go to services. You can read blogs. You can watch videos of me talking about the different things we do, the science behind them. Huge amount of education available on the website. So I definitely encourage people to do that. We have locations. We have 3 locations, opening our 4th in October in the Denver metro
Yay.
area. So we're all over Denver. And the goal is in 2 we're going to have about 10 locations in Colorado, and then we branch out to the Mountain West. So we will be coming to New Mexico,
Yay.
Arizona, Idaho, Wyoming, Montana. My sister wants to go to Texas. I refuse to fly to Texas, but we'll just. But those are the best. But really, the website is the best place. And then I'm on LinkedIn. I'm very active on LinkedIn. It's Dr. Flora Waples. There's only one of me. I'm easy to find. So yeah, reach out and hopefully my goal really is just I want people to know their options. You know, their knowledge is power. Sometimes people can do these procedures, people can choose not to do these procedures. Either one of those is okay. I'm not stamping out aging, I'm making aging optional. So come to the website, visit me on LinkedIn, learn what your options are, and then choose which ones are right for you. And that's what it's all about. And everybody's answer is different. That's a beautiful thing. But knowledge is the key. So that's what I'm here for.
It sure is. Thank you so much, Dr. Waples. It's been an absolute pleasure.
Oh, thank you, Carol. It's such a pleasure to be here.
And to our listeners, wherever you are in the world, we wish you every blessing. Bye for now.